Welcome to Test Day Panic, your rapid-fire review designed to sharpen your focus for your upcoming exam. We've distilled the critical information you need to ace it. Let's jump in. When we talk about elimination, understanding the fundamental terms is absolutely essential. Let's start with a key metric.
That's right. The glomerular filtration rate, or GFR, is crucial. It's the volume of water filtered out of the plasma per unit time, typically between 100 to 120 milliliters per minute. Think of it as the kidney's efficiency rating.
So if that vital filtration starts to slow down, what does that indicate?
A slowdown quickly leads to conditions like oliguria, which is defined as less than 500 millirals of urine in a 24-hour period.
Okay, less than 500.
And even more severe is anuria. That's less than 50 millirals in 24 hours, often just described simply as no urine output. These are critical signs.
And what about the buildup of waste products in the blood? That has specific terms too, right?
It does. This brings us to azotemia, which refers to that measurable rise in serum toxins like BUN, creatinine, and uric acid. Now, pay close attention here. When that azotemia progresses and becomes symptomatic—
Symptomatic.
Yes, meaning you see clinical signs like hyperkalemia, edema, or maybe anemia. That's what we call uremia. It's the symptomatic stage, really.
Gotcha. It's also vital to remember that elimination isn't static. It naturally changes as we age.
Absolutely. We see a natural decrease, a yo decrease in GFR as we get older. Beyond that, structural and functional changes happen, like sclerosis of the glomerulus and vessels, bladder constriction can become more common, benign prostatic hyperplasia or BPH in men, and definitely an increased risk of urinary incontinence. Age matters here.
Okay. Our bodies also use a complex hormonal system to manage fluid and blood pressure, and these directly influence kidney function. Which hormones are most critical?
Three really stand out. First, ADH, from the pituitary, causes us to retain water. Simple as that.
Right, retain water.
Second, aldosterone, from the adrenal glands, makes it retain sodium.
Sodium retention.
And finally, renin. That's produced by the kidneys, part of the RAAS system, and it ultimately leads to vasoconstriction, which bumps up blood pressure.
When assessing kidney function, what abnormal things should we look for in urine, and what blood tests are the most reliable indicators?
In urine, the presence of protein, what we call albuminuria, that's a really significant abnormal finding.
Okay, protein in the urine.
Yep. For serum labs, creatinine is our gold standard. Its levels are almost exclusively determined by kidney function, so it's incredibly reliable.
Makes sense.
BUN also indicates kidney function, but liver function can kind of muddy the waters there, making creatinine often more specific.
And why is monitoring potassium levels so incredibly crucial when kidneys are involved?
Potassium. Because it's primarily excreted by the kidneys, right? So any imbalance can have the greatest emergent clinical significance due to its direct danger to the heart. We're talking serious arrhythmias.
Right, the heart. That's key.
We also look at pH, as the kidneys play a huge role in acid-base balance through bicarbonate excretion.
Let's shift gears to specific kidney conditions now, starting with glomerulonephritis. What exactly is happening in this condition?
So this is basically an inflammation caused by an antigen-antibody complex. It's a large molecule, this complex, and the kidneys really struggle to excrete it.
So it causes blockages.
Exactly, leading to blockages in the GFR. It often follows something like a strep throat infection, which is why it's most common in children.
Okay, post-strep. And what are the primary clinical concerns and treatments for this inflammation?
The main complications really arise from fluid volume overload. For acute cases, treatment usually involves steroids to reduce the inflammation, and dietary sodium should definitely be limited.
Steroids and low sodium.
Correct. We also retreat with antibiotics to make sure bacteria aren't spreading, but you have to be cautious with prolonged antibiotic therapy. It can lead to secondary infections like yeast infections or even C. diff.
Good point. Moving on to pyelonephritis, which is essentially a kidney infection. What's distinct about this one?
This is indeed an infection of the kidneys. What's interesting, or maybe concerning, is that in older populations, early symptoms might be very subtle. Like the first sign could simply be increasing confusion or delirium, not your typical UTI symptoms. And if pyelonephritis becomes chronic, it can unfortunately lead to end-stage renal disease because of scar tissue formation in the kidneys.
Wow. Okay. So how do we prevent this serious infection?
The most important prevention in client teaching really revolves around proper hygiene, preventing those urinary tract infections, UTIs, from ascending up to the kidneys in the first place.
Makes sense. Let's discuss nephrosclerosis next, which, as the name suggests, involves hardening, right?
That's precisely it. This is the hardening of the vasculature leading to the kidneys. It's often caused by plaque buildup or other issues leading to a narrowing of those afferent arterioles. It's a common cause and also a consequence of hypertension.
Okay. What's the key patient teaching here to manage or prevent its progression?
Patient education has got to emphasize a low cholesterol diet, definitely a low sodium diet. Smoking cessation is huge, and meticulous blood glucose control, especially vital for diabetic patients.
Got it. Now, for nephrotic syndrome, you mentioned a mnemonic earlier. This condition sounds like it's letting too much out.
You've got that
Okay.
spot on. Remember, ions, like in itis syndromes, glomerulonephritis, mean it's keeping things and O's, like inotic syndromes, nephrotic, mean letting too much out. So nephrotic syndrome involves increased capillary permeability in the kidneys, allowing way too many vital substances to escape.
Okay, otic is out. And what is often the root cause of this particular syndrome?
This is critical. Syndromes are often caused by something else. In about 9 out of 10 cases, nephrotic syndrome is triggered by sepsis.
Sepsis. Wow.
Yeah, it leads to massive proteinuria. Yeah, huge protein loss in the urine, which then causes excessive third spacing. Why? Because there's not enough albumin left in the blood vessels to hold the fluid in. Result, widespread edema.
That sounds severe. Given these effects, what's the priority for treatment and what should we teach our patients?
The absolute priority is always to find and treat the underlying cause, which is often sepsis.
Find the cause, right.
Other interventions include things like IV fluids, vasopressors maybe to support blood pressure, and replacing albumin to help pull that fluid back into the vasculature. For patient teaching, advise them to watch for foamy urine that indicates protein and to regularly test their urine for protein. Daily weights and strict intake and output IOs are also crucial for monitoring that fluid balance.
All right, let's break down acute kidney injury, AKI. We often categorize the causes, right? Starting with the injury stage.
Yes, we split the causes into pre-renal, intrarenal, and post-renal. Pre-renal causes relate to anything that affects blood flow to the kidneys.
Like what, specifically?
Think decreased cardiac output leading to ischemia, decreased blood pressure, sepsis again, decreased fluid volume, dehydration, or even hemorrhage. Anything reducing perfusion.
How do we prevent and treat those specific pre-renal issues?
Well, prevention is key. Maintain fluid volume, strict IO is essential. Aggressively stop any bleeds, and correct underlying issues like infection to restore adequate blood flow.
Okay. Next up, intrarenal causes, which are problems originating within the kidney tissue itself.
Right. These include inflammations in the kidney like glomerulonephritis and pyelonephritis, or, very commonly, adverse reactions to medications. Think IV contrast dyes and nephrotoxic meds like the phenomycins.
How do we prevent these intrarenal problems from happening or getting worse?
Ideally, avoid nephrotoxic medications if possible. If you have to use them, you monitor labs meticulously. That includes peaks, taken 30-60 minutes after a dose, and troughs, taken 30 minutes before the next dose, typically checked every third dosing.
Peaks and troughs. Got it.
Maintain fluid levels, that's crucial, especially when using contrast dyes. We can also use nephroprotective meds like N-acetylcysteine. It protects both kidneys and liver. Smells kind of sulfurous, usually taken orally. IV bicarbonate can also help by reducing the acid load. And of course, treat any underlying kidney diagnoses.
It makes sense. Finally, postrenal causes, which involve obstructions to urine elimination after it leaves the kidneys.
Exactly. Yeah. This includes anything interfering with urine flow downstream. So UTIs, kidney stones, BPH in men, or issues with Foley catheter care.
And what about prevention for these postrenal causes?
Yeah, it comes down to basics often. Maintaining proper GU hygiene, diligent catheter care, keeping hydration levels up, and treating underlying diseases like UTIs with antibiotics or BPH with surgery or meds like Flomax.
Okay, moving from acute to chronic. Chronic kidney disease, CKD, is systemic, affecting nearly every body system. Let's run through the key points, system by system, and the critical interventions, starting with neuro.
Right, neurological.
Yeah.
Patients may experience altered mental status, even seizures. For AMS, altered mental status, dialysis is a key intervention. For seizures, prevention involves a decreased sodium diet and using anticonvulsants if seizures have already happened.
What about the respiratory system? Fluid shifts can be a big problem there.
Pulmonary edema is a common and serious issue, definitely. Interventions include O2 as needed, increased fluid intake is critical, and again, dialysis to pull off that excess fluid.
And cardiovascular effects, you said this is the #1 cause of death for CKD patients.
Absolutely. Fluid volume overload leads to very high blood pressure. And here's a tricky part. The kidneys, even failing, might still pump out renin trying to boost GFR.
So it makes the hypertension worse.
Exactly. It's a challenging paradox. Antihypertensives are essential. Also, hyperlipidemia with increased triglycerides puts patients at risk for atherosclerosis, so statins are usually prescribed.
What gastrointestinal considerations are vital for these patients?
Anorexia, maybe issues with diet noncompliance, and nutritional imbalances are really common. Interventions involve a diet decreased in sodium, cholesterol, and fluids. Supplements like Nipro that's specific for kidney patients and other vitamins are also important.
Hematological issues, particularly anemia, are also common, right?
Very common. Anemia is caused by decreased erythropoietin production by those failing kidneys. We treat this with EPO-alpha, a synthetic erythropoietin given sub-Q, usually 3 times weekly, often conveniently scheduled during their dialysis appointments.
Okay. Integumentary problems like skin issues.
Yes, edema is one, and pruritus, that severe itching occurs because unfiltered salts get deposited under the skin. This can lead to skin breakdown. So, good hygiene with fragrance-free soaps and lotions is key for prevention and comfort.
Metabolic considerations sound extensive here, covering a lot of electrolytes.
They are. It's complex. We see electrolyte imbalances like increased sodium, potassium, and phosphorus, but conversely, decreased calcium.
So high Na, K, phos, but low calcium.
Exactly. Diet interventions focus on low sodium, potassium, and phosphorus, but high calcium and iron. Meds include phosphorus binders. These must be taken with food calcium supplementation and vitamin D to help absorb that calcium. Patients often have compensated metabolic acidosis.
Meaning their body's trying to balance the acid.
Right, often by breathing faster to tachypnea. This is treated with bicarbonate supplements.
Finally, what musculoskeletal changes can we expect in CKD?
Cramping and bone pain are common complaints. You get bone destruction occurring as parathyroid hormone, PTH, tries to correct the decreased calcium levels by pulling calcium out of the bones. Not good long-term.
Okay, that covers CKD systems. Let's delve deeper into fluid volume overload, a critical issue with signs across various systems. What would you see, say, on the pulmonary side?
Pulmonary side. You'd notice an AER increased respiratory rate, O2 levels might be dipping, decreased O2 saturation, and you'd hear those telltale crackles upon auscultation. Sometimes even frothy pink sputum, which is a bad sign.
How about the abdominal area?
You'd likely see pitting edema there, and a positive fluid wave test would confirm a site that's fluid building up in the peritoneal cavity.
What about the extremities and skin? What are the signs there?
You'd observe cooling of the skin, more prominent pitting edema, maybe even weeping, which is like a yellowy fluid leaking from the skin. Jugular venous distension, JVD, would be visible in the neck, and in severe cases, anasarca that's just widespread, generalized edema all over.
Neurologically, what signs would indicate fluid overload?
Patients could present with altered mental status, fatigue, maybe signs of cerebral edema, and even seizures. Those seizures are often related to critically decreased sodium levels from all that extra water diluting it, dilutional hyponatremia.
And on the cardiac front, what would the heart be doing?
You'd see ear increased blood pressure, a bounding pulse, you can really feel it, and an ear increased heart rate as the heart works harder to pump all that extra fluid around.
What laboratory values would confirm this fluid overload?
We typically expect EO decreased sodium and O's to decrease BUN levels, primarily because everything's diluted by the excess fluid.
So, given all these signs and labs, how do we intervene effectively? What's the plan?
Okay, interventions. We implement strict sodium restrictions, obviously. Meds include loop diuretics like furosemide, brand name Lasix. It's crucial, though, to monitor for fluid volume deficit once diuresis starts.
Right, don't overshoot.
Exactly. Maintain strict IOs, conduct daily weight, same time, same scale, and use telemetry for cardiac monitoring. Seizure precautions are essential due to those potential sodium shifts. Practical things include elevating the legs, meticulous skin care to prevent breakdown from edema, and activity only is tolerated, which might mean dead rest for some.
What about more serious medical interventions?
That includes dialysis, of course. Sometimes mannitol is used, that's an osmotic diuretic, but you need filter precautions because it can crystallize at room temperature. Albumin can also be given, but typically only with concurrent dialysis to help pull fluid back, and O2 as needed naturally.
Got it. Now, hyperkalemia, too much potassium, incredibly dangerous due to cardiac effects. What are the most concerning signs we'd look for on an ECG?
The biggest concern is always cardiac. You'll see arrhythmias like those classic peak T waves, a widened QRS complex, maybe prolonged PR intervals, PVCs, premature ventricular contractions, and potentially lethal rhythms like VTach or VFib.
Scary stuff. What about heart rate?
Early on, the heart rate might actually be tachycardic, but later, as things worsen, it can become dangerously bradycardic.
Any other general symptoms that might indicate high potassium besides the heart?
Patients might be irritable, experience fatigue, complain of generalized muscle weakness, and feel short of breath.
What are the critical interventions for hyperkalemia? These feel like high priority, must-knows.
Absolutely high priority. Medications like Lokelma and Kayexalate help actually remove potassium from the body. Diuretics like Lasix are used to promote excretion. Critically, we use calcium gluconate. This doesn't lower potassium, but it immediately stabilizes the cardiac membrane, protecting the heart.
Stabilizes the heart. Okay.
Then, insulin plus dextrose, D50, is given. The insulin drives potassium from the bloodstream back into the cells, and the D50 prevents hypoglycemia from the insulin. It's also vital to immediately stop any meds that can increase potassium, like spironolactone.
What's important to monitor closely during these rapid interventions?
You need frequent electrolyte labs, kidney function labs, continuous telemetry for cardiac activity, and meticulous IOs. Constant vigilance.
Let's connect low calcium and high phosphorus now, which often occur together in kidney disease. What are the key symptoms for hypocalcemia and hyperphosphatemia?
The hallmark sign is tetany, which progresses through stages. Early on, patients might report tingling, paresthesia, maybe numbness, usually starting peripherally fingertips and toes.
Okay, tingling first, then.
In the mid-stage, you'd start noticing muscle cramps and muscle spasms, indicating increased neuromuscular excitability.
And what about the late stage classic signs we absolutely must recognize?
The classics. Those are Shafai-Stek sign, you tap the cheek, the facial muscles twitch, and Trousseau sign, inflate a blood pressure cuff, and the distal arm curls up and spasms. We might also see laryngospasms, which can compromise the airway, and various cardiac dysrhythmias.
Okay, Shafai-Stek's and Trousseau's. What about their bones and overall skeletal health?
There's an increased risk of fractures, definitely osteoporosis develops, brittle nails, and generalized bone pain because the body's leaching calcium from the bones.
Any other general symptoms we might see?
Patients might also experience fatigue and altered mental status.
How do we manage this complex imbalance of low calcium and high phosphorus? What's the approach?
Diet is key. Advise patients to avoid shelf-stable foods. Phosphorus is really common as a preservative in things like dark sodas, lots of processed foods, and canned goods.
Avoid the preservatives. Makes sense. And what medications are typically used?
Calcium supplementation is given, including IV calcium gluconate for acute severe symptoms. Big caution here. It's a vesicant, so administer it as a slow push, preferably through a central line, or at least a large bore IV in a proximal vein.
Slow push vesicant, got it.
Vitamin D supplementation is also given to help absorb calcium. And phosphate binders, like sevelamer, are crucial. They must be taken with food to bind dietary phosphates and prevent absorption.
What practical interventions can we put in place for patient safety, especially with the risk of fractures and tetany?
Fall precautions are essential. Think grippy socks, clear pathways. Consults for occupational and physical therapy are also really important for maintaining mobility and prescribing weight-bearing exercises to help strengthen those bones.
Okay. Let's quickly review catheter-associated urinary tract infection, or CIUTI, prevention strategies, high-yield stuff.
Right. We use stat lock devices, or similar securement, to prevent catheter movement, reducing irritation. And the overarching goal is always to remove catheters as soon as medically possible, ASAP.
Get it out.
Consider transitioning to a pure wick for female patients if appropriate, but be mindful of pressure injury risk. Set the suction pressure to low the green setting and change the wick every shift or PRN if soiled.
When is a catheter truly necessary then, given these risks? What are the indications?
Okay, valid indications include refractory urinary retention, that means needing like 3 straight caths without relief, or for managing large wounds in the genital region to keep them clean and dry. Also, certain bladder surgeries require continuous irrigation via catheter. And finally, for strict IOs, especially in critically ill patients with multisystem organ failure, where precise fluid monitoring is absolutely paramount.
Got it. A quick note on renal angiography.
Yeah. It just has more significant pre- and post-procedure care needs compared to other diagnostic tests, but it's specifically reserved for assessing kidney perfusion, visualizing that blood flow.
Okay. Dialysis requires access to the bloodstream. What are the common types of access we'll encounter, and what's the nursing care associated with them?
We have several options, each with pros and cons. Let's start with the temporary ones first.
Tell us about the vascath.
A vascath is a type of central line access inserted directly into a major vein, usually the subclavian or internal jugular. It's relatively easier and quicker to implant. Placement is verified by X-ray, showing the tip and the superior vena cava. It's non-permanent and leaves no scarring.
Okay, but what are the downsides?
It has a higher risk of infection compared to other types and can generally only remain for about 2-3 weeks. It can also be accidentally dislodged, can get occluded or clawed off. And there's a risk of pneumothorax during placement, so verifying placement and monitoring for signs like shortness of breath are crucial. Nursing care demands strict sterility, especially during dressing changes. And importantly, floor nurses typically do not use this line for anything other than dialysis treatments.
Right, and the permacath, how is that different?
It's similar to a vascath, a central line access, but it's tunneled under the skin before entering the vein. This tunneling significantly reduces the infection risk compared to a vascath, allowing it to last much longer, potentially up to 1 year.
So lower infection risk, longer use.
Exactly. Its other pros and cons regarding implantation, non-permanence, risk of being pulled out or occluded, and pneumothorax risk are similar to the vascath. But that reduced infection risk is the key advantage. Nursing care also emphasizes strict sterility and verifying placement.
What about the more permanent options, the AV graft and AV fistula? These sound quite different.
They are. An AV graft joins an artery and vein using a piece of synthetic tubing. A downside is that it tends to fail more often than a fistula because it's a foreign body, prone to clotting or infection.
Okay, graft uses tubing. What about the fistula?
An AV fistula directly joins an artery and vein surgically. This allows high-pressure arterial blood to flow into the vein, causing the vein to enlarge and strengthen. We call this maturing. It boasts the least complications overall, can potentially last lifelong, has very little infection risk compared to catheters or grafts, and less disfigurement than a bulky graft.
Sounds like the preferred option, if possible. Any cons?
The main con is that the arm with the fistula must be meticulously protected, which can sometimes lead to body image issues or lifestyle adjustments for the patient.
What's the essential nursing care for both an AV graft and an AV fistula? This seems like critical patient safety information.
Absolutely critical. Patient teaching must explicitly cover NO restrictive garments, no watches or tight jewelry, and absolutely no blood pressure cuffs or needle sticks on that limb. Ever.
No BP, no sticks. Got it.
Daily assessments are key. You need to palpate, feel for a thrill, which is a buzzing or vibration like a cat's purring, and you need to auscultate, listen for a bruit, which is a whooshing sound. Both indicate good blood flow through the access.
Thrill and bruit. Feel and listen.
Exactly. Any changes in the thrill or bruit or any signs of infection like redness or swelling must be reported immediately. That access is their lifeline.
Okay, and the actual dialysis procedures themselves. Let's quickly differentiate between them.
Right. Hemodialysis is the most common. It's the functional replacement of the kidneys, usually done 3 times a week in a clinic or hospital. A specialized type you might see in the ICU is CRRT, or continuous renal replacement therapy. This is used for critical, hemodynamically unstable patients. It runs much slower but constantly, like 150 milliliters per minute, providing gentler fluid and solute removal.
Slow but constant for unstable patients. What about peritoneal dialysis? How does that work?
With peritoneal dialysis, or PD, a Tenkoff catheter is surgically placed through the abdominal wall into the peritoneal cavity. Dialysate, a special sterile fluid, is infused into the abdomen. It dwells there for a set time, usually 20-30 minutes or longer, depending on the prescription.
And the peritoneum does the filtering.
Exactly. The peritoneum, the lining of the abdominal cavity, acts as a natural semi-permeable membrane. Waste products and excess fluid diffuse from the blood vessels in the peritoneum into the dialysate. Then the fluid is drained out and discarded. This cycle is repeated several times a day or overnight.
What are the upsides and downsides of peritoneal dialysis? Seems quite different.
Pros include the ability for patients to do it at home, which offers way more independence and often fewer dietary and fluid restrictions compared to hemodialysis.
But are there limitations?
Yes, only about 8% of dialysis patients are actually clinically suitable for PD. Cons include a significant risk of infection, specifically peritonitis and infection of the peritoneum. That's a major complication.
How would peritonitis show up?
Key signs are a rigid, board-like abdomen and changes in the appearance of the drained dialysate. It might become cloudy or have fibrin strands. Other cons include potential abdominal discomfort, body image issues due to the catheter or abdominal distension from the fluid, difficulty laying flat or sleeping properly, sometimes shortness of breath if there's a lot of fluid, less precise control over results compared to hemodialysis, and sometimes bowel discomfort or constipation.
Okay, lots to consider with PD. Finally, a quick important note on wet weights and dry weights in the context of dialysis.
Right. Wet weight is simply the patient's weight when they arrive for dialysis, reflecting their fluid-overloaded state before treatment. Dry weight is the optimal target weight for the patient after a successful dialysis treatment, representing their weight once the appropriate amount of excess fluid has been removed without causing dehydration. It's an estimate of their true weight without extra fluid.
Wet before, dry after. Got it. We've covered a huge amount on kidney function and its systemic impact. Now, let's shift our focus to another vital system often impacted by age or disease, the sensory organs, starting with conditions affecting vision. These are also high yield. Let's begin with age-related macular degeneration, AMD.
Okay, AMD. As the name suggests, it's age-related and, unfortunately, largely unpreventable. It affects central vision. Treatments primarily involve injections into the eye that help clear up some issues and, more importantly, prevent further disease progression.
And nursing care focus.
A key practical point for nursing care involves ensuring the patient has a driver arranged for all visits, and especially after treatments, as vision can be temporarily affected, impacting driving ability.
Makes sense. Next, glaucoma, caused by high intraocular pressure, or IOP.
Yes, glaucoma. It typically has a slow, insidious onset, leading to a gradual loss of peripheral vision first. It often goes unnoticed initially.
Are there different types?
There are two main types you need to know. Acute, also called closed angle, which is sudden, very painful, and a true medical emergency requiring immediate care to prevent permanent vision loss. And chronic, also called open angle, which is the more common gradual type. Vision loss is often unnoticed by the patient until it's quite advanced, and it's not considered an immediate medical emergency like the acute form.
Okay, acute is emergency, chronic is gradual. How do we treat it, especially with eye drops, which seem common?
Eye drops are definitely a mainstay of treatment. The correct administration procedure is critical for effectiveness and safety. Remember, wash hands thoroughly, gently pull the lower eyelid down to create a small pocket, instill the prescribed number of drops into the conjunctival sac, not directly onto the cornea, and then apply gentle pressure with a finger against the lacrimal duct near the nose for about 30 seconds.
Why the pressure on the duct?
That helps prevent the medication from draining into the nasal passages and being absorbed systemically, which can cause side effects elsewhere in the body. We want it to stay in the eye.
Got it. What's crucial to teach patients about living with glaucoma to manage their condition and safety?
Patients need education on maintaining good lighting in their environment to maximize vision. They need awareness of fall and driving risks due to that reduced peripheral vision. They absolutely need to know the proper eye drop procedure. And they need to recognize symptoms to watch for, such as sudden eye pain, halos around lights, or worsening nausea, which could indicate an acute attack or worsening pressure.
Okay. What about cataracts? What's happening there and how is it managed?
With cataracts, the normally clear lens of the eye becomes cloudy or opaque. This is usually due to protein clumping together as we age. It causes blurry vision and light scattering, making things look hazy or glaring. It's usually age-related and typically not a medical emergency.
And the treatment?
Treatment is surgical. The clouded natural lens is removed and replaced with a clear synthetic intraocular lens, an IOL. It's a very common and usually successful surgery.
Post-operative care sounds extremely important for cataract surgery to ensure proper healing. What's involved?
Absolutely. Patients will follow a strict eye drop schedule, typically including an antibiotic drop, a steroid drop to reduce inflammation, and often a lubricating drop. They must avoid wearing contact lenses in that eye. An eye patch or shield is usually worn at night, and sometimes during the day initially, to protect the eye from accidental rubbing or trauma. They should also try not to sleep on the operative side.
Any activity restrictions?
Yes. Crucially, they must avoid bending at the waist in a way that puts the head below the level of the heart. They also need to avoid activities that cause straining, like heavy lifting, forceful coughing, or straining during bowel movements, as these can increase intraocular pressure.
What home teaching is important after cataract surgery?
Patients should avoid driving at night until their vision stabilizes and their doctor clears them. They should wear UV polarized sunglasses when outdoors during the day to protect the eye. And maintaining a diet rich in eye vitamins, antioxidants, fruits, and vegetables is always good advice for overall eye health.
Okay. Hemianopsia, that's loss of vision in half of the visual field. Is that often related to something else?
Yes, it's typically caused by a stroke or sometimes a brain injury affecting the visual pathways in the brain. The visual deficit itself isn't the primary emergency. The priority is treating the underlying stroke or injury.
So the teaching focuses on adaptation.
Exactly. Teaching focuses on patient safety. Strategies like scanning their environment to compensate for the blind spot, being aware of the direction people should approach them from, and modifying their living space to adjust for their new visual abilities. Driving is almost always restricted or prohibited.
A detached retina sounds like an immediate emergency, is it?
It definitely can be, yes.
Yeah.
The retina, the light-sensitive tissue at the back of the eye, pulls away or detaches from its normal position. This can be caused by an injury, think trauma to the head or eye from sports, car accidents, maybe even electrocution. Or it can occur spontaneously, especially in individuals who are very nearsighted with high corrective prescriptions.
What are the symptoms?
Pain. Symptoms include the sudden onset of new floaters like little specks or cobwebs drifting in the vision and flashing lights. But notably, there is usually no pain associated with a retinal detachment itself.
No pain, but floaters and flashes. Treatment.
Treatment is surgical reattachment of the retina. The sooner it's treated, the better the chance of preserving vision.
What are the immediate actions for acute eye emergencies, like penetrating trauma or chemical exposure? What do we do first?
Okay, first actions. For penetrating eye trauma, something stuck in the eye, the absolute priority is to stabilize the object. Do not try to remove it. You might use a paper cup or something similar taped over it to protect it. Then cover both eyes, the injured one and the uninjured one,
Why both eyes?
to prevent any sympathetic movement of the injured eye when the uninjured eye moves. Then get the patient to emergency eye care immediately. For chemical exposure, the critical first step is immediate and copious flushing with water or saline. Flush, flush, flush for at least 15-20 minutes, holding the eyelid open. Then seek emergency medical attention. And just connecting back for retinopathy, often seen in diabetic patients. The main intervention is truly to treat the underlying diabetes, meticulous blood sugar control. There isn't a specific cure or direct care for the retinopathy damage itself beyond managing that root cause effectively.
Okay. Lastly, quick mention of aphasia, which relates to communication challenges.
Right. Aphasia refers broadly to language disorders, usually caused by damage to the language centers of the brain, often from stroke. It can be classified into several types. Global aphasia means severe communication difficulties across the board. Receptive aphasia is difficulty understanding spoken or written language. And expressive aphasia is difficulty producing speech or writing, even if comprehension might be relatively intact.
Okay, global, receptive, expressive. Got it. You've just powered through a massive amount of essential material, really hitting those high-yield points for your exam. We covered everything from the tiny glomerulus to the vital role of specific hormones, how to spot critical electrolyte imbalances like hyperkalemia, and even essential sensory conditions that impact patient care and safety.
Remember, every detail we've discussed is interconnected. These systems don't work in isolation. As you head into your test, try to think not just about the definitions or the lists, but how these dysfunctions truly manifest in a real patient, and how that critical thinking drives your priorities and interventions. Understanding the why behind each condition will really solidify your knowledge.
Keep those concepts sharp, review your notes, and good luck on your exam. You've put in the work, you've got this, and we're confident you're going to do great.